Welcome back to the Deep Dive. Today we are tackling a topic that is, it's literally the bread and butter of general surgery.
Oh, absolutely.
If you walk into any surgical ward anywhere in the world, you are going to see this. It keeps the lights on in private practice, and it fills the emergency lists at 2 a.m.
It's the staple.
We are talking, of course, about hernias.
It is the absolute staple of the surgical diet. But, as with many common things, familiarity can breed contempt. It's just so easy to think, oh, it's just a hernia, and miss the nuance that turns a routine case into a disaster.
Exactly. And that is our mission today. We are doing a comprehensive, interpreted deep dive into Chapter 64 of Baily and Love's Short Practice of Surgery, the 28th edition.
Specifically, Chapter 64, the abdominal wall, hernia, and umbilicus, a real classic.
Now, before we cut skin, we need to drop our standard disclaimer.
Of course.
We are interpreting this chapter. We're trying to make it digestible, memorable, and frankly, a bit more fun than just staring at a textbook page for 3 hours.
This is not a replacement for reading the text.
No. Think of this as a ready reckoner for your revision or, your clinical practice.
Absolutely. Think of this as the conversation you have in the coffee room after rounds. I'm going to try to synthesize the data into concepts you can actually use when you have a patient in front of you. We aren't reading the book at you. We are extracting the gold.
And I'm going to play the role of the exhausted medical student or the junior doctor who's just trying not to look stupid in front of the consultant.
Right.
I'll ask the questions that I think everyone is thinking but might be too afraid to ask.
And there are no stupid questions in surgery, only expensive mistakes. And in hernia surgery, those mistakes can be life-threatening.
I love that. Okay, let's start with the hook. Why the abdominal wall? Why do we care so much about this particular bit of anatomy? It just seems like a wrapper for all the important stuff inside.
And that is the mistake everyone makes. You have to think of the abdominal wall as a high-performance pressure vessel. It's not just a wrapper. It has a dual conflicting function. It needs to be rigid enough to protect the organs and maintain intra-abdominal pressure, which is crucial for breathing, coughing, all that stuff.
Lifting.
Exactly, lifting. But it also needs to be flexible enough to allow you to twist, bend, and expand.
It's a structural engineering nightmare. It has to be strong and flexible.
A total nightmare. And Baily and Love uses a great implicit metaphor here. Think of the abdominal wall like a high-performance tire.
Okay, how like that?
You've got layers.
All
In
right.
a tire, you have the tread, the sidewall, the steel belts. In the abdomen, that's your muscle layers, the rectus abdominis, the obliques, the transverses.
Right.
When the sidewall of that tire weakens, the inner tube, which is the peritoneum and the bowel, bulges out, and that bulge is your hernia.
And just like a tire, I guess there are places where a blowout is more likely.
Precisely. Evolution has left us with some naturally occurring weak spots. We are not a seamless vessel. We have holes for things to pass through. The esophagus needs to get to the stomach, so we have a hiatus in the diaphragm. The spermatic cord needs to get to the scrotum, so we have the inguinal canal. The femoral vessels need to get to the leg. Every single one of those exit ramps is a potential weakness.
Plus the holes we make ourselves.
The man-made holes. Incisions. Every time a surgeon cuts that tire, it never heals back to 100% strength.
Really? What's the best you can hope for?
It's about 70% at best. So incisional hernias are essentially a failure of the abdominal wall to heal its own armor.
This brings us to a concept in the text that I found. Well, fascinating. It shifts the thinking from hernia as just a hole to something systemic. The text mentions that hernia might actually be a collagen disease.
This is a huge paradigm shift, a huge one. For a long time, we thought hernias were purely mechanical. You lift a heavy box, pop, you have a hernia.
Right, cause and effect.
But the evidence now suggests that many patients have an inherited imbalance in their collagen types.
So their actual building blocks are defective.
Yeah, precisely. They might have a ratio of, say, type 1 to type 3 collagen that produces weaker scar tissue or weaker fascia. This is why you see a strong correlation between patients with inguinal hernias and patients with abdominal aortic aneurysms.
Wow.
They are both failures of connective tissue tensile strength.
That is a scary connection, but it makes perfect sense. If your connective tissue is weak in the groin, it's probably weak in the aorta too.
And this explains why smoking is such a massive risk factor. It's not just about the coughing, which everyone assumes. No. Smoking impairs collagen maturation. It actively prevents your body from building strong crosslinks in the tissue. So if you are a smoker, you are chemically degrading the structural integrity of your abdominal wall.
You are literally rot-proofing your own tires.
In the worst possible way.
Okay, let's get into the clinical nitty-gritty. We need to establish a vocabulary, a severity ladder, if you will, because not all lumps are created equal, right?
Correct. Triage is everything. The bottom rung of the ladder is a reducible hernia. The patient says, "Doc, there's a lump when I cough, but it goes away when I lie down." You push it and pop, it goes back in.
Satisfying pop.
Very satisfying. That's generally safe. The contents are moving freely in and out. The next rung up is irreducible.
Okay.
It's stuck. It won't pop back in. But, and this is the key, the blood supply is fine. The patient might be uncomfortable, maybe a dragging sensation, but they aren't dying.
Then we get into the danger zone.
Incarcerated. Now, this is a term that gets thrown around loosely, but it literally means in prison. The bowel is trapped, it's irreducible, and because it's trapped in a small space, it is at a very high risk of progressing to the top rung.
Which is?
Strangulation.
This is the emergency.
This is the drop everything and go to theater moment. The blood supply is cut off. Usually the venous return gets blocked first, causing swelling, which then blocks the arterial supply. Ischemia leads to infarction, which leads to necrosis, perforation, and sepsis. If you miss a strangulated hernia, the patient can die. It's that simple.
There's a specific type of strangulation mentioned in the chapter that sounds like a ninja. The Richter's hernia. Why do I call it a ninja? Because it's a silent killer.
Richter's. It's a classic exam trap and a total clinical nightmare. Imagine only part of the circumference of the bowel wall gets pinched in the defect.
Not the whole tube.
No, just the anti-mesenteric border. Just a knuckle of the sidewall of the intestine.
So the tube itself isn't blocked.
Exactly. The lumen remains open. The patient might not have obstruction symptoms. They might still be passing gas or stool. They aren't vomiting.
Right.
But that pinched knuckle of bowel is dying. It can necrose and perforate without ever causing a classic bowel obstruction.
That is terrifying. So you have a patient who isn't vomiting, their bowels are moving, but they have this tender lump, and they were just getting sicker and sicker.
And if you see that, you have to think Richter's, especially in ephemeral hernias.
Okay, check-in question time to the listener. Imagine a patient comes in. They have a tender red lump in the groin. You try to push it back in, but it's rock hard and painful. It won't budge. They aren't vomiting yet. Where are we on the severity ladder?
That is incarcerated, and with the redness, which implies inflammation or ischemia, you have to assume it is strangulated until proven otherwise.
So it's an emergency.
It is a surgical emergency. Do not wait for vomiting. Do not pass. Go.
Moving on to part 2. The big 2. Groin hernias. Inguinal versus femoral. I feel like medical students spend half their lives trying to understand the inguinal canal.
And the other half forgetting it. It's true. Let's simplify it.
Please.
Don't worry about the layers of the spermatocord for a second. Just visualize the journey. In a male fetus, the testicle starts inside the abdomen near the kidney.
Right. Way up high.
Right. It has to get outside to the scrotum.
Because it likes it cooler.
Exactly. So it drags everything with it. It punches a path through the abdominal wall muscles. That path is the inguinal canal. It enters through the deep ring. A defect in the transversalis fascia runs down the canal and exits through the superficial ring.
So an indirect inguinal hernia just follows this pre-made path?
Yes. Think indirect equals the natural route. It follows the testicle. It's usually congenital. Basically, the tube of peritoneum that the testicle dragged down, processus vaginalis, it just didn't close properly.
It stayed patent.
It stayed patent. So bowel can slide right down that open slide all the way into the scrotum.
So if I see a hernia that goes all the way down to the testicle, it's almost certainly indirect.
Almost certainly. Direct hernias rarely, if ever, go into the scrotum.
Okay, so that's indirect. What about direct?
Direct is different. It's not using the pre-made tunnel. It's a wear and tear failure. It punches directly through the posterior wall of the inguinal canal.
This is where we have to talk about Hesselbach's triangle.
Ah, the Bermuda Triangle of general surgery.
Yeah.
Yes, you need to know the boundaries.
Okay, quiz me.
Picture it on the patient. Medially.
The rectus abdominis muscle, six-pack muscle.
Good. Laterally.
The inferior epigastric vessels.
Excellent. And inferiorly.
Inguinal ligament.
Perfect. So a direct hernia is medial to the epigastric vessels.
Right.
The floor of this triangle is just fascia, transversalis fascia. As we age, that fascia gets weak. Remember the collagen issue we talked about?
Yeah.
Intra-abdominal pressure pushes directly forward through that weak floor. It bulges out.
So visually, indirect goes down the tube, lateral to the vessels. Direct punches to the wall, medial to the vessels.
You've got it. And if you have both,
A hernia.
a hernia sac on both sides of the vessels.
A pantaloon hernia.
Because the inferior epigastric vessels are the crotch of the trousers, and the hernia sacs are the two legs straddling it.
I love surgical humor. It's so brutal.
Yeah.
Now we have to talk about the villain of the story, the femoral hernia.
Right. If the inguinal hernia is the goofy common nuisance, the femoral hernia is the silent assassin.
Why is it so much worse?
Anatomy. It's always anatomy. The femoral canal is a tiny space just below the inguinal ligament. It's where the lymphatics pass. The problem is the borders.
Okay.
It is bordered medially by the lacunar ligament. Some call it Gimbernat's ligament. This ligament is sharp, rigid, and completely unyielding.
So if bowel gets in there.
It effectively gets garroted. The neck of a femoral hernia is tight and unforgiving. Because of this, they have a massive rate of strangulation.
What are we talking?
Baily and Love cites that 50% of femoral hernias present as emergencies.
50%. 1 in 2. That is a staggering number.
It is, and here is the clinical trap. They are often missed, especially in obese patients. The lump is small, it sits below the groin crease, and it's often mistaken for a lymph node. And this is the really key part. Because the neck is so tight, there's often no cough impulse.
Wait, I thought cough impulse was the absolute definition of a hernia.
For inguinal, pretty much, yes. But for femoral, the neck is plugged so tight that the pressure wave from the cough just doesn't transmit into the sac.
So a doctor could miss it.
Easily. A doctor touches it, asks the patient to cough, feels nothing, and thinks, oh, it's just a lymph node. That patient go home and comes back a day later with a dead bowel.
That brings us to our first fictional case study. Picture this. A 75-year-old female comes in. She's a bit vague, maybe has some tummy ache. You examine her. She has a small, hard, non-tender lump in the upper thigh, just below the groin crease. You ask her to cough. Nothing happens.
This is the danger zone. This is classic. You are looking at a demographic elderly female that is prime for femoral hernia.
They're more common in women.
Much more common due to the shape of the pelvis. The hard lump is likely omentum or bowel that is incarcerated. The lack of cough impulse basically confirms it is trapped tight.
So if a junior doctor says, it's probably reactive lymph node, let's give antibiotics and see, what do you say?
I say, get a senior opinion or get an ultrasound immediately. You cannot sit on a femoral hernia. The rule is simple. Femoral hernias should always be repaired.
Always.
Always. There is no watch and wait like there is for asymptomatic inguinal hernias.
Got it. Femoral equals fix it. Now let's briefly touch on the surgery. We don't need to get too technical, but what are the main options?
Well, for kids, it's usually just a herniotomy. You find the sac, twist it, tie it off, cut it. Done.
You don't repair the muscle?
No, you don't need to. The muscles are healthy. It was just a patent tube that needed closing.
But for adults, it's different.
For adults, the muscles are weak. If you just stitch them together, which is called herniorrhaphy, things like the Bassini or Schultes repair, you are pulling tissue together under tension.
And tension is the enemy?
Tension is the enemy. It causes ischemia and the sutures tear through. That's why recurrence rates were so high. So we moved to the Liechtenstein repair.
The mesh repair.
The open, tension-free repair. You lay a flat piece of mesh over the posterior wall of the canal. You're reinforcing the tire.
Right.
And now, of course, we have laparoscopic repair, TAP and TAPP.
Ah, the acronym soup.
It's simple, really. TAP is totally extraperitoneal. TAP is transabdominal preperitoneal. Basically, both methods involve placing a large piece of mesh behind the muscles, covering all the potential holes, indirect, direct, and femoral from the inside.
And that's better.
It's great for bilateral hernias and for recurrent hernias where you don't want to dissect through old scar tissue.
Let's segue into part 3, mesh technology. To the layperson, I have to say, putting a plastic net inside a human body sounds a bit odd.
It does, but it's absolutely the standard of care. The logic is simple. Suturing tissue under tension fails. Mesh provides a scaffold.
The text talks about net versus sheet. What's that about?
So a net is porous. It has holes. You want the body scar tissue to grow through the holes. You want the mesh to integrate and become a reinforced layer of the body.
Okay.
A sheet like PTFE or Gore-Tex, it doesn't allow that ingrowth. It just gets encapsulated in a capsule of scar tissue. We tend to prefer nets.
There is this persistent myth that mesh shrinks. Patients hear this all the time. Don't use mesh, it shrinks.
Right. And Baily and Love is very clear on this. The plastic itself, the polypropylene, it does not shrink, it's inert.
So what's happening?
What happens is the scar tissue that grows into the mesh contracts. As any scar matures, it tightens. If you use a heavy, dense mesh with tiny pores, you get a solid plate of scar tissue that contracts massively, sometimes up to 50% of the area.
Wow.
This is why we now prefer lightweight, large pore meshes.
Large pores mean less foreign material, more flexibility, and a more natural scar.
Exactly. We want a flexible abdominal wall, not a suit of armor.
Now, where do we put this mesh? The text uses a great framework of placement planes.
The sandwich metaphor, I love this. Imagine the abdominal wall is a sandwich. The muscle is the meat.
Okay.
You can put the mesh on top of the bread, which is onlay. You can put it in between the meat, which is sublay. Or you can put it inside the sandwich entirely, which is intraperitoneal.
Onlay seems the easiest. You just stitch it on top of the muscle.
Easiest, but problematic. If the wound gets infected, the mesh is sitting right there in the soup. Plus, the physics are wrong. Intra-abdominal pressure pushes out. If the mesh is on top, the pressure is constantly trying to blow the mesh off the wall.
It's like trying to hold a door shut from the outside while someone kicks it from the inside.
Perfect analogy. That's why sublay or retromuscular is preferred. You put the mesh behind the rectus muscle.
So now?
Now, the intra-abdominal pressure pushes the mesh against the abdominal wall. The pressure helps fixate it. It's mechanically superior in every way.
And IPOM, intraperitoneal.
That's inside the cavity, touching the bowel. You have to use special coated mesh so the bowel doesn't stick to it and cause a blockage down the line. We try to avoid this now if we can, but sometimes in laparoscopic surgery, it's necessary.
Right. Let's move to part 4, ventral and incisional hernias, starting with the belly button. Umbilical hernias.
Super common. In kids, almost all of them close spontaneously. We usually wait until age 2 before we even think about doing anything.
But in adults, they don't just close on their own.
No. In adults, it's acquired. Obesity, pregnancy, heavy lifting. And technically, it's usually a paraumbilical hernia, a defect just above the true umbilicus.
There is a very specific and quite scary warning in the text about patients with liver cirrhosis and ascites.
This is a major red flag. If a patient has cirrhosis and a belly full of fluid ascites, their umbilical hernia is like the plug in a dam.
The pressure must be immense.
It's huge.
Right.
If you operate on that hernia without managing the ascites, 2 terrible things happen. 1, the wound just falls apart because of the pressure. 2, and worse, you can get a floodgate effect, where ascites leaks out, bacteria goes in, and the patient gets peritonitis and dies.
So, extremely high mortality. Proceed with extreme caution.
Extreme caution. You treat the liver failure first, always.
What about the Mayo repair? I feel like I hear about this one often.
The waistcoat over trousers repair, it's a classic. You overlap the fascia top to bottom.
Does it work?
It's good for small defects, less than 2 centimeters. But for anything larger, you really should be using mesh. The recurrence rates are just too high otherwise.
Moving up the midline, we find the epigastric hernia.
These are tricky little things. They are often mushroom-shaped. It's a tiny defect in the linea alba, and a little ball of extraperitoneal fat pops through.
And the text says they are disproportionately painful.
Yes. The lump might be the size of a grape, but the patient is in agony. That's because the fat is getting pinched in a rigid small defect. The fat can actually infarct, it can die, without the bowel ever being involved.
And then there is the Spigelian hernia. This sounds like something out of a spy novel.
The stealth hernia, I like that. It occurs at the Spigelian line, the outer edge of the rectus muscle.
That's why stealthy.
The reason it's stealthy is that it is often interparietal.
Meaning between the layers.
Exactly. It breaks through the inner muscle layers but stays underneath the outer oblique aponeurosis, so you might not feel a lump at all. The patient has pain, maybe signs of obstruction, but the exam is totally equivocal.
You need a CT scan to find it.
Usually, yes. And because the defect is small and has sharp edges, the strangulation risk is high.
Now, we face the big one, incisional hernia. The text calls this, and I'm quoting, the surgeon's failure.
It's a harsh truth, but it's not wrong. If an incision turns into a hernia, it means the closure failed. It happens in 10 to 50% of laparotomies.
Wait, up to 50%? That's huge.
In high-risk groups, yes. Infection is the biggest cause. If the wound gets infected, the fascia it dissolves, it turns to mush.
But technique matters too. The text outlines a specific rule for closing abdomens to prevent this. The small bites rule.
This has changed practice in the last decade. It really has. We used to take big, wide bites of tissue. Big bites for big surgeons. We were wrong.
So what's the rule?
The evidence now says small bites, about 5 millimeters of tissue, and small steps, 5 millimeters apart, you are effectively sewing a zipper. It distributes the tension evenly along the whole wound edge.
So lots of small stitches is much better than a few big ones.
Much, much better. It prevents ischemia at the suture line and leads to a stronger scar.
Let's do another check-in question. You have a patient who had a laparotomy 2 years ago. They now have a big bulge along the scar. A surgeon suggests, oh, I'll just stitch it back together again. Why is a simple suture repair a really bad idea here?
Because it has already failed once. The tissue at the edge of the hernia is scar tissue. It's weak. It has poor blood supply. If you just pull it together under tension, the recurrence rate is massive, over 50%.
It's doomed to fail again.
It's a recipe for recurrence. You need to use mesh to reinforce it. You need to bridge the gap or reinforce the repair. Simple suture repair for incisional hernia is malpractice, basically.
We're entering part 5, specialized, rare, and dangerous conditions. Let's start with the one that is pretty much guaranteed to happen if you do a certain procedure, the peristomal hernia.
Right. When we make a stomacolostomy or ileostomy, we are intentionally creating a hernia. We are pulling bowel through a hole in the muscle. It's no surprise that the hole gets bigger over time.
The text suggests we should be putting mesh in prophylactically when we make the stoma.
That is the current trend, yes. Don't wait for the hernia to form. Reinforce the tunnel with mesh at the very beginning. It seems to reduce the rate significantly.
Next up, obturator hernia. Talked about femoral being the villain. Obturator is the ghost.
The ghost. It's deep in the pelvis. You can't see it. You can't feel it externally. It happens in a very specific demographic. Thin, elderly women.
Why thin?
Because normally there is a fat pad in the obturator canal that plugs the hole. When you lose weight rapidly or are very frail, that fat pad disappears and the hole opens up.
And the telltale sign, the diagnostic clue.
The Hauschip-Romberg sign. The hernia sac compresses the obturator nerve. The patient feels pain referring down the inner thigh to the knee.
So an elderly lady with bowel obstruction symptoms and a sore knee.
You need a CT scan immediately. It's an obturator hernia until proven otherwise.
Then we have sportsman's groin or Gilmore's groin.
This is a diagnosis of exclusion. It is chronic groin pain in an athlete, usually a soccer or rugby player, caused by tearing or inflammation of the muscle attachments around the groin.
But is it actually a hernia?
Crucially, usually no. There is no hole. There is no bowel popping out. It's a soft tissue injury. The text is very firm on this. Surgery is a last resort. You treat it with physiotherapy and rest. Don't rush to operate on a groin that just hurts without a palpable lump.
Okay, let's talk infections. Necrotizing fasciitis. This is the stuff of nightmares.
It's gas gangrene of the abdominal wall. It often starts from a small scratch or an infected surgical wound. The bacteria, usually multiple types, release toxins that just liquefy the fascia.
What does it look like? What are the signs?
The patient is toxic. Septic shock. The skin might look gray or have these horrible blisters. And if you press on it, you might feel crepitus.
Crepitus.
It's a crackling sensation like pressing on bubble wrap. It's the gas produced by the bacteria under the skin.
And a treatment.
Radical debridement. You cannot fix this with antibiotics alone. You have to take them to the OR and cut out all the dead tissue. The text says, cut until it bleeds. You have to excise until you hit healthy bleeding tissue. It leaves a massive defect, but it's the only way to save their life.
Finally, a sign that bears a nun's name. Sister Joseph's nodule.
Sister Mary Joseph was a surgical assistant to Dr. William Mayo at the Mayo Clinic. She noticed that patients with a hard, irregular nodule at the umbilicus often had terminal cancer.
It's a metastasis.
Yes. Cancer, often from the stomach or ovary, spreads along the falciform ligament to the navel. If you see a hard, malignant-looking lump at the belly button, it's a sign of advanced metastatic disease. A very sobering sign.
Okay, we've covered a lot of ground. Let's pull it all together with part 6. A final case study challenge.
Let's do it.
Fictional case study 2. A middle-aged man is involved in a high-speed car crash. He was wearing a seatbelt. He had some bruising initially, but weeks later, he notices a bulge in his flank, kind of around the side of his back in the lumbar region. It gets bigger when he coughs.
This is a classic traumatic lumbar hernia.
How does that happen? It wasn't a penetrating injury.
No. The sudden deceleration and the force of the seatbelt literally sheared the muscle attachments off the iliac crest. It didn't cut the skin, but the muscle ripped apart underneath.
So it's a hernia caused by blunt force trauma.
Exactly. It's rare, but very specific to seatbelt injuries. It's difficult to repair because there's no good fascia to stitch to. You almost always need a big mesh repair for those.
All right, let's wrap this up with our Ready Reckoner summary. If the listener only remembers 5 things from this deep dive into Chapter 64, what should they be?
Okay, number 1. Hernia is a collagen disease. It's a systemic failure, not just a hole. Tell your patients to stop smoking.
2.
Groin anatomy. Direct is medial, think wear and tear. Indirect is lateral, think congenital. Hespeck's triangle defines the direct hernia, know those boundaries.
3.
Femoral hernias are dangerous. If you see a lump below the inguinal ligament, especially in a woman, assume it's dangerous. No cough impulse doesn't mean it's safe. It means it's trapped tight. Mesh. Mesh is your friend. Put it behind the muscle sublay for the best mechanics. And large pores are better than small pores.
And number 5.
Incisional hernias. Prevent them with these small bites technique. 5mm bites, 5mm steps. So a zipper, not a shoelace.
That is gold. And a rewind tip, if people are still confused.
If you are still fuzzy on the difference between TET PP and TET PP laparoscopic repairs, or the boundaries of Hesselbach's triangle, rewind to part 2. Those are absolute favorites for exams and for pimping on ward rounds.
Before we sign off, here's a provocative final thought. We talk about how incisional hernias are a failure of the abdominal wall. Now we're doing more and more laparoscopic surgery. We used to make one big cut. Now we make 3 or 4 small cuts.
The port sites.
Exactly. Are we just trading one big hernia risk for a swarm of smaller ones? The text mentions that about 1% of port sites herniate. With millions of lap cols and appies happening every year, that's a new epidemic of small, tricky hernias.
It is. And because the holes are small and the fascia is rigid, the strangulation risk is higher. It's definitely something we need to watch out for.
Something to mull over.
Yeah.
As always, go read the chapter, look at the diagrams of the mesh placements. They really help visualize the sandwich.
Knowledge is only useful if you can apply it. Go save some bowels.
See you in the next deep dive.